All right, so today we're going to start our discussion about airspace disease and chest radiograph with airspace disease here. So when you have airspace disease, there's a standard question: what can the alveoli be filled with that would give you airspace disease? So there's certain substances that come to mind that the alveoli can be filled with to give you airspace disease. What are they? The most common is
fluid,
water,
water.
so pulmonary edema. Then there might be
Pus, like
pus, pneumonia, right? Then you might have,
blood,
and that would give you diffuse pulmonary hemorrhage. Then you might have,
reflux.
Reflux?
What did you say?
Reflux.
What do you mean reflux?
Like food contents.
What?
Food contents. Food.
You mean aspiration?
Yeah.
Alveoli can be filled with food?
Yeah.
I wouldn't. No, I mean that's more like that's more like fluid, right? That's more like water if you're talking about aspirating stuff from your from your GI tract, I suppose. Cells, and then you have one other very unusual category, protein, right? So pulmonary edema, pneumonia, pulmonary hemorrhage, cells. So by the way, when we talk about cells, right? So there are certain neoplasms that can give you airspace disease. What are those neoplasms that can be associated with air bronchograms? When neoplasms can do that?
Mucinous.
Yeah, mucinous adenocarcinoma, and then kind of rarer than that, but can still occur in the lung as kind of an infiltrative neoplasm is lymphoma. The disease associated with protein is pulmonary alveolar proteinosis, right? So today we're going to talk mostly about pulmonary edema. So chest radiograph at admission looks pretty clear, and then 6 hours later, it looks like this. So how would we describe the abnormality on the chest radiograph? What do we have? We have the abrupt onset of bilateral consolidations, right? So this is most likely to represent what then? In terms of what are the alveoli filled with?
Fluid.
Fluid. So we're in the category of pulmonary edema. Right. Now, there is an approach when we're discussing pulmonary edema. There are two broad categories of pulmonary edema. What are those two broad categories?
Interstitial versus alveolar.
What?
Interstitial versus alveolar.
No.
Cardiogenic versus non.
Cardiogenic versus non-cardiogenic. Right. So how do you differentiate cardiogenic from non-cardiogenic pulmonary edema?
There's like cardiomegaly.
So one, you look at the heart size, right? See if the heart is big. What else do you look at? What are other things you look for? Pulmonary vascular congestion, curly B lines, pleural effusions, the typical things that go with cardiogenic pulmonary edema. So looking at this, do we think this is cardiogenic or non-cardiogenic pulmonary edema? Non-cardiogenic. So what are some causes then of non-cardiogenic pulmonary edema that you might think about for this particular case? He was normal on admission. 6 hours later, looks like this.
ARDS.
So ARDS could be caused. What else? Yeah, so if you got the history, the patient was found in a burning building or something, or acute inhalation, noxious inhalation can do that. Anything else?
You're muted on.
What?
You're muted on there.
Oh.
They can't hear you.
They can't hear us. Let's see, how can we fix that? Okay, now they should be able to hear us.
Hey, yeah, we heard you for the moment there.
Now can you hear me?
Yes.
Okay. So we said that when we're dealing with the category of consolidations, there are 5 substances that can fill the air spaces. There's water, pulmonary edema, pus, pneumonia, blood, pulmonary hemorrhage, cells like you might see with neoplasms such as mucin-producing adenocarcinoma, protein, pulmonary alveolar proteinosis. So today we'll spend most of our discussion on pulmonary edema. This is the chest X-ray on admission. This is the chest X-ray 6 hours later. So we have the abrupt onset of bilateral consolidation. So then we're thinking about pulmonary edema. There are 2 broad categories, cardiogenic versus non-cardiogenic. Here the heart is not enlarged. We don't see any pleural effusions or curly B lines. So we're thinking about non-cardiogenic pulmonary edema. So our differential diagnosis, what are some causes of non-cardiogenic pulmonary edema that might apply in this case? We suggested ARDS, we suggested noxious inhalation if the patient was found in a burning building. What else might we consider as cause of non-cardiogenic pulmonary edema?
Fat embolism?
Well, that's not going to occur in 6 hours, is it?
Neurogenic?
What?
Neurogenic?
If there's history of central nervous system injury, right? This patient also has this Swan-Ganz catheter, right? So one possibility might be
Preparation.
perforation. That's not going to cause pulmonary edema. Aggressive overhydration with fluid, right? So that might also result in pulmonary edema. This person was actually found in a lake, so this was an example of
ARDS.
near drowning. This was near drowning. Okay. So pulmonary edema, cardiogenic versus non-cardiogenic, and then we'll also talk about asymmetric pulmonary edema. In terms of the pathophysiologic categories in medicine, they divide it this way. These are various categories. As far as radiology, I think it's much simpler to approach it this way. Is it cardiogenic pulmonary edema caused by increased hydrostatic pressure versus non-cardiogenic pulmonary edema caused by increased permeability of the alveolar capillary membrane? So for cardiogenic pulmonary edema, increased hydrostatic pressure, thinking about CHF, fluid overload, renal failure, those are things that can result in cardiogenic pulmonary edema. You do have to be familiar with these numbers in terms of correlating the pulmonary venous wedge pressure with the findings on the chest radiograph. Normal is less than 12, grade 1, pulmonary venous hypertension 12 to 19, that's associated with cephalization. Grade 2 to 20 to 25 gives you interstitial edema, and grade 3, when it's greater than 25, then we have fluid in the air spaces, and that gives you alveolar edema. So normally, the upper lobe vessels are not as prominent as the lower lobe vessels because there's a gravitational gradient, and that should be judged on an upright chest radiograph. So that more lower lobe vessels then are more prominent than the vessels within the upper lungs. But once we have cephalization or grade 1 pulmonary venous hypertension, then the vessels in the upper lungs can start to appear more prominent, especially pulmonary veins up here within the upper lungs. You might have other clues like cardiomegaly, widening of the vascular pedicle towards the right, because that's associated with increased intravascular fluid. So in this particular patient, you can see some widening towards the right, prominence of these upper lobe vessels, and it's clearer when we compare it to a prior chest radiograph. So you can use this when you're looking at serial chest radiographs on the same patient. So here's our case where there's increased intravascular fluid and vascular redistribution, and here's the prior radiograph. So you can see the Superior vena cava here is widened compared to where it is here. This oval-shaped opacity down here, that also is widened. So what is the oval-shaped opacity?
Azygos.
Yeah, it's the arch of the azygos vein. And also the vascular pedicle here is widened, and it's widened to the right. So with increased intravascular fluid, you'll get distension of the superior vena cava, widening of the vascular pedicle to the right. And it can be useful when you're comparing serial radiographs on the same patient. Grade 2 pulmonary venous hypertension, we get interstitial edema. So here we see curly lines, increased interstitial markings, parabronchial cuffing, hilar haze. The hyla can appear enlarged and indistinct, and then thickened fissures from subpleural edema. So what are curly B lines? What are curly A lines? What are curly C lines? What are these curly lines? Well, let's start with the easy one. First of all, what all these lines have in common is what do they represent?
Septic.
What?
Interstitial space.
They represent thickening of what? They represent thickening of interlobular septa. That's what they all have in common. Curly B lines are what?
Peripheral.
Curly B lines occur in the periphery towards the edge of the lung. They're at right angles to the visceral pleural surface. Curly A lines, very hilar, they radiate out from the hilum. Curly C lines. Curly C lines are just overlapping of curly A lines and curly B lines. So curly B lines, these are the ones that we most commonly see. These occur in the periphery, so at right angles to the pleural surface. Curly A lines radiate out from the hilum, and curly C lines is just overlapping of the A and the B lines. All of these represent thickened interlobular septae. And this can help you if you're looking at a chest radiograph, somebody who's short of breath in the emergency room, in addition to the big heart, maybe some distension of the SVC. You kind of notice in the periphery, small pleural effusion, but also these lines in the periphery. Those lines are curly B lines. So that tells you that we have interstitial edema, also probably some curly A lines there too. So we have interstitial edema, so we can say we're thinking about interstitial pulmonary edema in this particular patient. And then on CT, what these represent is thickened interlobular septae. So here's a patient with some thickened interlobular septae from interstitial edema. And you can see they outline these structures. What are these structures that are outlined by these thickened interlobular septae? They are called what? What are these round things that are outlined very nicely when we have these thickened interlobular septae? What are those round things called? Those are called the secondary pulmonary lobules, right? So interlobular septae, when they're thickened, outline very nicely the secondary pulmonary lobule. Right in the center of the secondary pulmonary lobule, we have that little dot. What is that dot in the center of the secondary pulmonary lobule? What are those dots in the center of the secondary pulmonary lobule? What do they represent? Well, with the particular term we use for that, this is called the central lobular artery. All right? So that's the central lobular pulmonary artery. These guys in the periphery, what are these guys? See that guy there? What are those guys? What are these guys in the periphery of the secondary pulmonary lobule? These guys here.
Interlobular pulmonary arteries?
No, that's the point. You don't have pulmonary arteries along the interlobular septum. So those are what?
Veins.
Pulmonary veins, right? So pulmonary veins run in the periphery of the interlobular septae. The central lobular artery is found in the center of the secondary pulmonary lobule. What about the central lobular bronchiole? Do we see that normally on CT? Why not? Why don't we see the central lobular bronchiole on CT?
The resolution.
Wait, I can't hear you.
Is the resolution.
What?
The resolution.
Yeah, the walls of the central lobular artery are very thin, right? And the center is filled with air normally. So you usually don't see the central lobular bronchioles on CT because the walls are too thin to resolve. There is a condition where we do start to see the central lobular bronchioles. What is that? Whenever there's inflammation, the central lobular bronchiole might fill with pus, and what pattern does that give you on CT? Tree and bud. So that tree and bud pattern that you see on CT represents the central lobular bronchioles that are somewhat distended, filled with inflammatory secretions. Also, when you have inflammation around the central lobular bronchioles, we can also see that on CT, the inflammatory changes around it. Another case of pulmonary edema, interstitial edema, we can see the secondary pulmonary lobules very nicely outlined, thickening of interlobular septae, the heart's also enlarged in this case. There's peribronchiovascular thickening, or peribronchial thickening, another case of interstitial edema. Now, you don't want to mistake this for lymphangitic carcinomatosis, because lymphangitic carcinomatosis can also give you interlobular septal thickening. Can be smooth, but more characteristically, it's nodular, right? So nodular interlobular septal thickening is associated with lymphangitic carcinomatosis. So we get this a lot. We get CT scans for PE from the emergency room for patients who are short of breath, and it turns out that they have interstitial edema. So you can recognize this under CT scans as a thickening of the interlobular septae, maybe a little bit of patchy ground glass opacity. So notice the thickened interlobular septae, and we can say, all right, this is interstitial edema. See it a lot on our PE scans. When the fluid spills out into the alveolar spaces, then we have alveolar edema. Okay? So it can sometimes have a characteristic appearance where we have this bat wing or butterfly distribution of consolidations. Although this bat wing pattern tends to be associated with a particular cause of edema. Anybody know what it is, what the bat wing pattern most closely associated with? What? Renal failure. So renal failure tends to give you that bat wing, although you can see it you can't see it with all kinds of pulmonary edema. But pleural effusions, cardiomegaly with pulmonary edema consolidations can change rapidly, and the distribution may also depend on patient position. So if the patient is right side down, likes to lie right side down, it can be worse on the right side. So that butterfly pattern, very typical of pulmonary edema. 44-year-old woman presents to the emergency room with acute onset of shortness of breath. We look at the chest radiograph. What do we notice?
Bilateral passage.
Yeah. So, we have an ET tube, we have an NG tube, but there are these bilateral patchy opacities. What do we think this represents?
Pulmonary edema.
Pulmonary edema, especially given the topic of today's lecture, yes, might suggest that it is pulmonary edema. And of course, the next stop for this patient will be CT for PE, of course. There's your CT for a PE scan. What does it show? Well, first, what do we see? What do we see in the lung parenchyma to explain the abnormality on the chest radiograph? Yeah, so we have ground glass opacity, somewhat more confluent consolidation there in the left lower lobe. What else do we see? What are these guys?
Pleural effusions.
Pleural effusions. So what are you thinking? You're thinking what?
Pulmonary edema.
We're thinking pulmonary edema. And we talked about the categories. They are,
Grade 1, grade 2.
no, the
grade
two broad categories of pulmonary edema.
Cardiogenic.
Before that, cardiogenic, or
cardiogenic.
do we think this is cardiogenic or non-cardiogenic?
Cardiogenic.
Okay, so somebody's not muted out there. Okay, so we think this is cardiogenic. So what makes you think it's cardiogenic?
This is cardiomegaly.
What part of the heart is enlarged?
The left ventricle.
So we think the left ventricle is enlarged. What about the left atrium?
Left atrium is big.
Yeah, the left atrium is also enlarged, okay? So, any idea why might this patient have cardiogenic pulmonary edema? Any ideas, any thoughts? Well, what we'll do is we'll reformat the images, and remember, this is a CT for PE, this is not a cardiac CT. So we've reformatted the images in terms of the views that we usually use for cardiac imaging. What kind of view is this?
Two-chamber.
That's a two-chamber view. This chamber is, and that guy,
The ventricle.
left ventricle. What kind of view is this? Yeah, so we have some short axis views. So now, looking at the heart, do we notice anything?
There is a hypodensity on the wall.
Yeah, so here in the subendocardial region, kind of anterior and lateral there's the subendocardial area of decreased enhancement, of hypoattenuation. What could that represent?
Acute infarct.
Could represent an acute infarct, right? So the next step for this patient, the next stop would be
Back up.
cath lab. And it turns out, you can see, and her enzymes were positive, as it turns out. Her cardiac enzymes were positive. And so the culprit lesion, she had an acute MI due to obstruction of an acute marginal branch here. Okay. So sometimes, these findings can be made on a routine CT scan. Well, not routine, but a PE CT scan with thin sections and contrast enhancement. The most common cause of cardiogenic pulmonary edema with normal heart size is what?
Myocardial
Is
infarction.
myocardial infarction, right? So that can give you pulmonary edema with normal heart size. You can also see it with an acute arrhythmia, but MI, myocardial infarction, is more common. Right? So acute MI is the most common cause of cardiogenic pulmonary edema with normal heart size. So we have another case where we have consolidations. The attenuation of the consolidations is
Ground glass.
ground glass. What is this pattern called?
Peripheral.
Well, I don't know. I wouldn't call this peripheral. I wouldn't call that peripheral.
Crazy paving?
Crazy paving. What makes you say this is crazy paving? Why do you look at that and go, that's crazy paving? What is it about this that you say, okay, that's crazy paving? What is it?
Because there's intralobular and interlobular septal thickening?
Yeah, so you have ground glass opacity with interlobular septal thickening, right? But there's also intralobular septal thickening. There's reticularity actually inside the secondary pulmonary lobule. So you have ground glass with interlobular and intralobular septal thickening. It's geographic, meaning that there are areas of the lung that are also spared. So that appearance, when we see that, we call that crazy paving. Now, when you see crazy paving, as far as the textbooks, the particular disease that they describe that is associated with crazy paving is what?
Protein-alveolar hyperproteinuria?
Pulmonary alveolar proteinosis, right? That's the classic disease associated with crazy paving. However, when you see crazy paving in clinical practice, it's more likely to be something else. And what is the most common something else that might be associated with crazy paving appearance in clinical practice?
Pulmonary edema.
Pulmonary edema, right. This is a case of pulmonary edema that looks like crazy paving. So in clinical practice, crazy paving, pulmonary alveolar proteinosis is extremely rare, but almost all cases that you come across will have crazy paving. But if you see crazy paving in clinical practice, it's much more likely to be caused by something else. So pulmonary edema is a very common cause of crazy paving. What are other common causes of crazy paving? So think of things that might give you ground glass consolidation. Yeah, pneumocystis pneumonia, right. Pneumocystis pneumonia can also give you crazy paving. So talked about pulmonary edema. There are other things too, more unusual things like lipoid pneumonia. There are case reports of mucin-producing adenocarcinoma giving you crazy paving also. But pulmonary edema is the most common thing, and in terms of infections, viral pneumonias, pneumocystis pneumonias, for crazy baby. Right. So, of course, patient comes in short of breath, emergency room, gets a PE scan, as most of them do, and this PE CT scan looks like this. This is also very common around here. What drug can do this?
Opiates like
Yeah,
heroin.
opiate overdose. So we'll find a young person on the streets in Newark, bring them in, found down, they're in pulmonary edema. So it turns out it's drug overdose. Also, it's very common for those patients to have basilar consolidations of aspiration. So that's something else that we commonly see. Okay, but opiate overdose can also cause pulmonary edema. Sometimes with pulmonary edema, you can see this gravitational gradient actually inside the secondary pulmonary lobule. That's called an intralobular gradient. You'll see that the dependent portion of the lobule here is just slightly increased in attenuation compared to the rest of it. So even inside the secondary pulmonary lobule, you might see an intralobular gradient with pulmonary edema. Okay. So causes of non-cardiogenic pulmonary edema. This is usually increased permeability of the alveolar capillary membrane. There are many causes, ARDS, very common cause, toxic inhalation, opiates, many other things that can also give you non-cardiogenic pulmonary edema. So starting with ARDS, this occurs from alveolar capillary injury, leakage of edema fluid into the alveoli. The edema is prolonged because the fluid is protein rich and the oncotic forces for resorption are not present. So treatment requires high concentrations of oxygen, high ventilatory pressures, because the lungs become very stiff. They're decreased compliance, and many times the opacities that we see in the lungs represents atelectasis because the lungs are very stiff. So there are many causes of ARDS. I'm sure you're familiar with these. Now, some definitions. So diffuse alveolar damage, that's the histologic pattern of injury that we see associated with ARDS, and we'll see it associated with other causes, many causes of ARDS really. Acute lung injury. This is a clinical syndrome associated with diffuse alveolar damage on pathology, the PaO2 FiO2 ratio defined there, less than 300. ARDS is a clinical syndrome with acute symptoms, diffuse pulmonary opacities, exclusion of cardiogenic pulmonary edema, and your PaO2 to FiO2 ratio is even lower, less than or equal to 200. AIP, what does AIP stand for? Acute interstitial pneumonitis, right. So that is one of those idiopathic interstitial lung diseases, and essentially what it amounts to is idiopathic ARDS, idiopathic cause of diffuse alveolar damage. Patient comes into the hospital, short of breath, they go into ARDS, we never really have a cause. So that's acute interstitial pneumonitis. Now, as far as the phases of ARDS, there's the edema phase, and these phases can overlap, then the formation of hyaline membranes, inflammation, and the fibrotic phase. So it goes through these different phases. So you can see how the progression goes in terms of days. The fibrotic phase tends to begin, once you're more than a week out from the acute injury. So the exudative phase, we get hyaline membranes, protein-rich edema fluid, necrotic cells, that's days 1 to 6. Then there's the subacute proliferative phase, proliferation of type 2 pneumocytes, that's days 4 to 10. And then that transitions to the chronic fibrotic phase where we get organizing fibrosis. So what happens here is all of this stuff that is spilled out into the alveolar air spaces becomes incorporated by fibrosis into the alveolar walls. So the mechanism of fibrosis here that we see with ARDS is different than what we see with usual interstitial pneumonitis or idiopathic pulmonary fibrosis. Here the fibrosis occurs in the interstitium, whereas here what happens is the stuff that is spilled out into the air spaces becomes incorporated into the alveolar walls. That's called fibrosis by accretion. And so when we get into the fibrotic phase, you can see the thickening there of the alveolar walls from fibrosis, and of course that is going to impair their abilities to transmit oxygen through there, and oxygenation will be impaired. Something else about ARDS, the findings might be delayed up to 12 hours after onset of symptoms. So the patient might crash on the floor, you get a chest radiograph, and you may not see much in terms of consolidations, and then a few hours later, you get blooming of the bilateral consolidations, bilateral usually consolidations, and they persist days to weeks. You'll be reading the chest radiographs from the ICU day after day after day, and you're reading his bilateral consolidations unchanged, unchanged, unchanged. So they tend to persist. And then it can go on to develop fibrosis. Another thing we can see with the consolidations from ARDS, because the lungs are very stiff, what we see here in the dependent regions is atelectasis, and there's this gravitational gradient here, where you'll see the dependent portions of the lungs are denser or increased in attenuation compared to the rest of it. So you can have ground glass and opacities in the rest of the lung, but the dependent portions of the lung tend to be where you have the most confluent dependent consolidations. And so the way these patients can be treated also is by rotating the patients to get a more even distribution of oxygen throughout the lungs. And so on the initial CT scan here, when the patient was lying on their back, you can see that the opacities are denser in the dependent regions. After the patient has been prone for 12 hours, you can see that the opacities have moved a little bit more anteriorly, again following that gravitational gradient with ARDS. So we can see ground glass opacities also with ARDS throughout the lungs. And once we see fibrosis, we see this as traction bronchiectasis during the fibrotic phase of ARDS. So you'll see the beating of the airways, some irregularity of the airways. You might still see opacities surrounding the airways during the fibrotic phase of ARDS. Now, many of the complications of ARDS, most severe of those might be barotrauma. And there's a complication that's illustrated on the chest radiograph there. What is it? Pneumomediastinum, yeah. This patient has pneumomediastinum, but they're also tracking up into the neck. So because they require high P pressures to ventilate the lungs, barotrauma is a very common complication. So those are some of the pneumothorax, pneumomediastinum, pulmonary interstitial emphysema, and dermatoseals. And then, of course, they can have superinfection, pneumonias, and progression to lung fibrosis from ARDS. Pulmonary interstitial emphysema, this is when the air dissects from barotrauma into the interstitium, and it can give you these irregular collections of air within the interstitium. So that's pulmonary interstitial emphysema. Dermatoseals, this also represents dissection of air into the interstitium, but this forms these round, thin-walled collections of air within the interstitium. So those are dermatoseals that can also occur as a complication of barotrauma. And then fibrosis, after recovery from ARDS, we might see some traction bronchiectasis, and some irregular opacity, then some opacities, peribronchial opacities also. Interestingly, we don't see honeycombing from fibrosis from ARDS. Usually we don't get honeycombing. We see traction bronchiectasis, but not honeycombing. And then what can also be, what's also interesting about the fibrosis from ARDS is that it's thought that the fibrosis occurs as a reaction to oxygen or oxygen toxicity. And so it occurs in the areas of the lung that are better oxygenated. And if the patient's lying on their back, that tends to be the anterior regions of the lung. So the fibrosis might predominate in the anterior regions of the lung. So the atelectasis, the dependent atelectasis in the ARDS kind of protects those regions of the lungs from oxygen toxicity. So the traction bronchiectasis, the fibrosis might be more predominant in the anterior regions. So in this person, in the more acute phase of ARDS, you can see the dependent consolidations, and then after recovery, some traction bronchiectasis here, but more so in the anterior portions of the lungs, not in these areas where the consolidations were. And then here's an example that we had also here. So you can see there's some parabronchial opacities in the anterior portions of the lungs, some traction bronchiectasis. So this is fibrosis in this patient after ARDS. Nicely demonstrated also on this sagittal image. You can see the irregular airways. So what kind of reconstruction is this? Hmm? Well, what else have I done to bring out the contraction bronchiectasis?
Like a
MINIP, yeah. This is a MINIP. So you're used to looking at MIPS for looking at vascular work. That's going to show you the densest pixels within any particular slab. But if you want to look at the airways, or if you're looking for emphysema, or if you're looking for something very low in attenuation like air, then we use MINIPs. So these are slabs where we're displaying the lowest attenuation pixels within the slabs. So that's good for looking at airways and emphysema MINIPs. Differentiating pulmonary edema from ARDS. So cardiogenic pulmonary edema coincides with symptoms. ARDS might be delayed. Perihilar, all lung zones, parabronchial cuffing, less common. Septal lines, we talked about the curly B lines, not so much with ARDS. Air bronchograms common with cardiogenic edema, not so much with ARDS. It's thought that the fluid also spills into the airways with ARDS, and so that's why the air bronchograms are not as common. The consolidations change rapidly with cardiogenic edema. They change slowly with ARDS, widened vascular pedicle, not usually widened, cephalization, no cephalization. Pleural effusions, common with cardiogenic edema, not so common with ARDS. Now, there are other causes of non-cardiogenic pulmonary edema. We'll touch on some of these things also. Toxic inhalation, so inhalation of these substances. These chemicals act as irritants and can also result in edema. What causes Silofiller's disease?
Nitrogen dioxide.
What's that?
Nitrogen dioxide.
Okay, and the long-term complication of Silofiller's disease is?
Bronchiolitis.
Bronchiolitis obliterans, right? That's the long-term complication. So Silofiller's disease, in the first few days after grain storage silo is filled, nitrogen dioxide forms when that's inhaled. It mixes with the fluid in the lungs, forms nitric acid that acts as an irritant to the air spaces and the tracheobronchial tree, so the patients can develop shortness of breath, consolidation, so it's a form of non-cardiogenic pulmonary edema. Can damage the airways, so the long-term complication is damage to the smaller airways or bronchiolitis obliterans. Smoke inhalation. Acutely after smoke inhalation, the patient can be asymptomatic and have a relatively normal chest radiograph. And then later on, the patient can develop pulmonary edema. So how do they know patients are at risk for this? How do they know patients are at risk for, when they show up in the ER, they may not be short of breath, they may not have consolidations on the chest radiograph, and they can crash 1 or 2 days later. How do they know the patients are at risk? Well, they look for soot around the nose and the mouth. That's one thing. What lab tests do they check? For smoke inhalation, carbon monoxide.
Yeah.
Right. So if there are elevated levels of carbon monoxide, right, then there's patients at increased risk for smoke inhalation. They have to be watched very carefully. Okay. Opiates, we've talked about this also. So opiates, overdosing there can also cause pulmonary edema. It's thought to be permeability edema. Cytokines, drugs, any drugs can result in pulmonary edema. Interleukin-2, 25% of patients develop pulmonary edema, usually interstitial edema. Near drowning, so initially the consolidations that you see might be the aspirated fluid, but that can clear. But whatever's been aspirated, especially if they're contaminants, and it can also damage the alveolar walls, and then these patients can also develop pulmonary edema that can be delayed. How do we put these two images together?
Neurogenic.
Yeah, so neurogenic pulmonary edema is associated with injuries to the brain or the spinal cord. So those patients can also develop pulmonary edema. So it's thought might be from an intense sympathetic nervous system discharge and permeability edema endothelial damage. But we can see pulmonary edema in patients with neurogenic edema. For whatever reason, it may be upper lung predominant pulmonary edema from neurogenic pulmonary edema or neurogenic pulmonary edema. Okay, and this one, of course,
Animals.
yeah, so long, and we've seen it here that kind of like this also, where the patient has a long bone fracture, and then after manipulation of the long bone fracture, they can also go on to develop the fat embolism syndrome. So this tends to occur a few days after the injury. Why is that? It doesn't occur acutely with the injury. Why is it delayed after the injury?
As you like break down on like the.
Yeah, because it's a breakdown of the fat. So what happens is the fat droplets enter the bloodstream and they're hydrolyzed by tissue lipases, form free fatty acids. They're toxic to the lung endothelium, and that results in the pulmonary edema. Symptoms develop 1 to 2 days after trauma. So the triad lung findings, CNS findings like confusion, stupor, and petechial rash. So that's fat embolism syndrome. It's not uncommon to receive a CT request for PE to rule out fat embolism syndrome. Can you diagnose it on a CT scan? Why not?
You go see the fat. I mean,
What?
It's the breakdown products, you're not gonna see that.
Yeah, so these are microscopic particles, right? You're not going to see them on CT. Although I did come across one case where we actually could see the fat. And there are some case reports that actually show you that you can actually, in some cases, rare cases, you can actually see macroscopic fat within the pulmonary arteries, but that's extremely rare. So in most cases, you really just see, you don't see PE, you don't see any filling defects, you just see the consolidations in the lungs from the pulmonary edema as a result of the fat embolism syndrome. Okay. So usually bilateral consolidations with fat. So it's the history really that helps you there, thinking about fat embolism syndrome. Amniotic fluid embolism, so this occurs, of course, late in pregnancy. So, of course, you'll have the history for that. Acute airway obstruction, prolonged hypoxia can result in overactivity of the sympathetic system, negative intrapleural pressure as the patient struggles to breathe. That can also result in pulmonary edema. So what can be interesting about the pulmonary edema that occurs from asphyxia is that the cortex can be spared in the periphery. So after arriving in Denver, this patient became short of breath. What is this? High altitude pulmonary edema or mountain sickness, right? So this is another form of non-cardiogenic pulmonary edema. So the elevation greater than 11,000 feet, pulmonary edema can occur 3 hours to 3 days after ascending. It's thought to result from hypoxia and heterogeneous vasoconstriction, PA hypertension, increases capillary permeability, but of course, the history of arriving someplace at high altitude and then developing pulmonary edema shortly after arriving there. So this is a 25-year-old man, cough, fever, chest pain, some elevated white count, consolidations here on the chest radiograph, HIV negative. CT scan kind of looks like this. So how would you characterize the appearance on CT? What would you say? Well, what's abnormal?
There's consolidations of
Yeah.
dependent lobes.
Right, so we have consolidations, right? What about the distribution of the consolidations?
Posterior, lower,
Yeah, these are not posterior, right?
but there's ground glass up
Right, there's ground glass.
on the upper lobe, so peripheral distribution.
Yeah, there is a striking, somewhat peripheral distribution of consolidations here, right? So when we see a pattern of peripheral distribution of consolidations, what are things that we think about? I can't hear you.
Hypersensitivity.
Well, no, not hypersensitive pneumonitis, no.
Eosinophilic.
So eosinophilic pneumonia certainly is something that, you might think about, so you'd want to check the eosinophil levels on the patient. What else?
Pulmonary edema.
Pulmonary edema, although pulmonary edema is not typically peripheral, right? That tends to be more perihilar. Atypical pneumonia can be anywhere, but doesn't have a typical peripheral distribution. Except there is one type of pneumonia that does have a peripheral distribution. What pneumonia is that? Well, you better get it right. You've seen a lot of it a few years ago. COVID, yeah. COVID has a peripheral distribution of consolidations, right? So that's something that you might think about. Peripheral distribution of consolidations, we also think of what else? We also think of, what does OP stand for? Organizing pneumonia, right? So peripheral distribution of consolidations, you can also see that with organizing pneumonia. So what activity should we ask the patient about? And in this patient, it turns out fulfills the criteria for acute lung injury. What?
Vaping.
Yeah. So vaping-associated lung injury. So the criteria for diagnosis not very satisfying, but use of a vaping product within 90 days. Pulmonary opacities, no pulmonary infection, no evidence of alternative plausible diagnosis. So it can give you a pattern of acute lung injury or organizing pneumonia where you might have peripheral distribution of consolidations, other patterns associated with it, eosinophilic pneumonia, an acute eosinophilic pneumonia pattern, or hypersensitivity pneumonitis. And it's thought that these products might be responsible for the injury that we see with the vaping. The chest X-ray here shows
Unilateral consolidation.
there's unilateral consolidation. There's another finding. The patient also has a chest tube. How do we put that together? Re-expansion pulmonary edema, right, or reperfusion pulmonary edema. So re-expansion or reperfusion pulmonary edema, so that can occur if the patient had a pneumothorax or pleural effusion that was drained, the lung re-expands, the rush of perfusion to that lung then results in pulmonary edema. There are other things that can also give you asymmetric pulmonary edema, unilateral or asymmetric pulmonary edema. This patient had a large pleural effusion, and especially if it's been around for a few days or more, what happens is that the collapsed lung can develop some hypoxic damage. And so once that lung is re-expanded, there's a rush of perfusion to the lung, the capillaries are leaky, so the patient gets pulmonary edema on that side. So that's re-expansion or reperfusion pulmonary edema. Here's another very nice example. Big pleural effusion, chest tube, lung re-expands, and you get pulmonary edema within that re-expanded lung. So reperfusion pulmonary edema. So as we said, it tends to occur from a lung that was collapsed due to large pneumothorax or pleural effusion. We kind of went through the mechanism. Chronicity of collapse greater than 3 days, that allows for the lung to be damaged. All right. Unilateral pulmonary edema is common after what surgical procedure?
Transplant.
Yeah, which lung was transplanted?
The normal one.
No. Which was the normal one? You tell me which was the normal one. Remember, the lung transplant, the transplanted lung itself is hypoxic. So that's also reperfusion edema. This is a lung that was transplanted. So this patient received a lung transplant for what underlying disease? What's wrong with this lung? Oh, what's wrong with this lung? Yeah, emphysema. So this patient received a lung transplant for emphysema. So it's common to develop reperfusion pulmonary edema in a transplanted lung. You can also have reperfusion pulmonary edema after a certain procedure they do in IR. What is that?
PE.
Thrombectomy for PE. Again, when they remove the thrombi, you get reperfusion to that lung, and that can result in reperfusion pulmonary edema. So those are some causes of reperfusion pulmonary edema. Patient lying right side down, so that gravitational dependence can also result in asymmetric pulmonary edema. So this patient has a tumor, but this patient also has emphysema. When there's emphysema, you can also get an asymmetric distribution of pulmonary edema. Where you have the bullae, where you have the emphysema, you're not going to see the consolidation. So that can also give you an asymmetric distribution of pulmonary edema. Here's another example. It's these bullous changes here in the upper lungs. Pulmonary edema goes to the areas where there is more lung parenchyma. So that can give you an asymmetric distribution of pulmonary edema. And then we can also have contralateral to an obstructed pulmonary artery. So if there's a PE that occurs on the left side and the patient goes into pulmonary edema, that PE protects the left lung from pulmonary edema. So you can have pulmonary edema contralateral to an obstructed pulmonary artery or ipsilateral to an obstructed pulmonary vein. So in this case, this patient turns out as pulmonary edema here in the right lung, especially the right upper lobe. Why? What? Well, there's a mediastinal mass, right? And that mediastinal mass could be obstructing what? Yeah, pulmonary vein. What is this guy? Yeah, it's a dilated azygos filled with dense contrast, telling you that what's obstructed. Well, what is
SVC.
Yeah, the SVC is obstructed. You don't see it there. Okay, so this patient has a mediastinal process obstructing veins. The SVC can also obstruct the pulmonary veins, resulting in pulmonary edema in the right upper lobe. Tumors can do that, but also benign disease like fibrosing mediastinitis, as in this case it was fibrosing mediastinitis, causing obstruction of the pulmonary vein and SVC, resulting in pulmonary edema. This patient has a history of myocardial infarction and develops consolidation there, mostly on the right side. How do we put that together?
Acute mitral regurg.
From
Papillary muscle rupture.
papillary muscle rupture, yeah. So papillary muscle rupture gives you acute mitral regurg that's not well tolerated, results in pulmonary edema. The mitral regurg can be directed towards the right pulmonary vein, especially the right upper lobe pulmonary vein. So that can result in asymmetric pulmonary edema, worse on the right side. So that's rupture of the papillary muscle. All right, so that is our discussion of pulmonary edema. So let us move on to the quiz.